Hi, everyone. Welcome to today's live chat about returning to in-person school. Thank you for joining us and taking time out of your day. My name is Jenny Radesky. I'm a developmental behavioral pediatrician and a media researcher here at C.S. Mott Children's Hospital, and I'll be your host for today's chat. So I'm going to introduce our panelists in a moment, but first a few housekeeping items. You can submit questions at any time for our panelists to answer during today's chat. Questions can be submitted by commenting on this video, but please note that your name or profile name will be visible to others participating. If you prefer a more anonymous option, you can send a private message to us via Facebook or email us at ask-mishmed, that's M-I-C-H-M-E-D, at med.umich.edu. That's ask-mishmed at med.umich.edu. So one thing we want to say first off is we won't be answering questions today about specific school districts reopening plans. I know that's on a lot of parents' minds, but plans vary so much by different districts. We really want to address the family and child experiences that are occurring throughout Michigan as you adapt to the school changes that will happen. And we want our answers to be relevant to whatever learning environment your child will be in. If you can't stay for this whole chat, or you want to share the recording with a friend, a video of the chat in its entirety will be available on our CS Mott Children's Hospital Facebook page, our Michigan Medicine Facebook page, and our Mott Twitter account. It will also be posted to the Michigan Medicine YouTube channel. So now I'd like to let our panelists introduce themselves. We'll start with you, Alison.
Hi, my name is Alison Tribble. I'm a pediatric infectious diseases specialist here at Mott.
Great. And now we also have Terry Bravender here.
Hey, I'm Dr. Terry Bravender. I'm the Division Director of Adolescent Medicine here at CS Mott Children's Hospital and also Professor of Pediatrics and Psychiatry.
Great. Thank you both for spending the time today to answer some of these really important questions as parents and families adapt to what's obviously been a challenging school year. It's been challenging for families and educators, and now some students are starting to return to face-to-face school after months of remote learning during the pandemic. Others are continuing to do remote learning at home. So this is an exciting milestone as for our communities, but for many parents, they may have big questions about anything from safety to supporting their children's and teens' behavioral, social, and emotional growth as you readjust again to this new normal in their learning environments. And as other families continue to manage the challenges of virtual school, we want to be able to support all of you with whatever knowledge we've gained, either through our clinical practices or through the research that's been published about how kids are doing this year. So let's move on to the questions. I'm going to start with one that was really, about this big picture question of how safe is it to reopen schools and bring kids back together in person at this time. So the question is, what does the data tell us so far about how reopening schools may fuel COVID-19 spread in communities, and if children are super spreaders? Another related question is, should we be more worried about reopening schools now that the more contagious strain of the virus is here? So I'm going to send these first to Dr. Tribble because I know you know a lot of the data on how kids and whether kids spread COVID-19 in schools.
Thanks. Yeah, these are all really great and important questions, and they're on everybody's mind. I think, we've learned a lot since the start of the pandemic, first with the complete closure of schools and then with gradual reopenings in different places around the country and overseas as well. I think that, at this point in time, we actually have really encouraging data that this is a safe move for schools to start returning to in-person education. There have been several good studies that have come out that have shown that the rate of transmissions within schools is really, really low, often much lower than it is in just the general community. For example, there was a study out of North Carolina over 9 weeks. They had only 32 in 11 school districts, only 32 in-school transmissions, whereas there were 700 people in the schools that contracted COVID-19 outside of schools. And based on their local levels, they should have had, if spread was the same as it was in the community, they should have had 800 to 900 cases that occurred in the school with transmission in the school. So really putting those mitigation measures in place has made a really significant impact. And I think the other really important thing that came out of that study was that they had zero student to staff transmissions. I know that's a lot of people's concern given the higher risks of COVID for adults, but they didn't have any adults who contracted COVID from children. So I think there's other studies that we could talk about as well, but they really all show the same thing. And I think it's nice to have these studies that were done here in the United States to really show that in our settings, this can happen. There's data from other countries as well to support this. I think there has, as far as, whether children are super spreaders, I don't think there's any data to say that children for sure are super spreaders. I think early in the pandemic, we weren't really sure about the role of children in spread. There was, clearly fewer children are getting very sick, fewer children are getting infected overall. Some of that has to do with the amount of exposure they have versus whether they actually do get sick. I think that, we are still seeing lower rates in children overall. There was a large study out of India that did show, kind of contrary to what we thought initially, that children can play a significant role in spread, often among their same age contacts. Although, it didn't demonstrate that they were specifically fueling transmission or super spreaders themselves. It did show that in general, super spreading events are very key to transmission of COVID. So I think all of this together, just is a constant reminder that we have to maintain very, very strong, mitigation practices in schools, not just one, but layers and layers of these safety practices. And then I guess to your last question about the variants, certainly this has been in the news a lot. Everyone is really, concerned about what does it mean for these variants. I think the biggest thing we know so far is they do seem to be more transmissible. So that's, certainly a concern. Is that going to result in more COVID cases being transmitted in school if these variants become, more common in our communities? I think we're all going to be watching this very closely. At this point in time, I don't think there's any reasons for schools to say we should, drastically change our plans because of this. I think we just don't know yet. What we do know is that, or what we think we know so far, is that the reason for increase in transmissibility is more related to how the virus binds to the receptors in our own bodies. So all of our mitigation strategies that we've already been using should still be just as effective. So I think that's really reassuring. And, we will just continue to learn more. And I think as long as schools and parents and communities are really careful with reopening, I think it's absolutely safe to do so.
And I think just to build on your answer, I think it's really reassuring that the state is collecting really real-time data about when infections are occurring in schools, so we can keep track of trends of whether a variant is causing more transmission than we were seeing before. And I also, just also wanted to, what I've said to parents too, is that a lot of the super spreader events are largely things where people are unmasked and doing things like singing and laughing and like in each other's personal space. And it has not been in places where there's so many layers of mitigation put into place. So let's talk a little bit more about those specific sort of mitigation measures, because as families have lived at home, they've been, attending virtual school unmasked, kind of maybe in your pajamas, maybe, kind of not having to pay strict attention to how much they're washing their hands. And as our, so the question here is, as their district, this audience member's district is planning to switch from hybrid to full capacity, even at the high school, their plan states that students will have 3 feet of social distancing when possible. And then teens will be in very close contact during the day, and it will be difficult to distance in hallways and other common areas. So what question should we, the parents, be asking the school? And how can we make sure we're following the right mitigation measures to stay safe and contain COVID spread when schools reopen? And I just, to build on this, I'm also curious, Dr. Bravender, if you think, is this going to feel weird for teens? Are teens going to, the teens and take care of, how have they been doing with some of these mitigation strategies, when they've had to go back and either keep their distance or navigate, being closer to each other?
So I can start with that, Alison, and I'll let you get to the science of the distance. I think that most of the teens I've taken care of are very invested in not only keeping themselves safe, but in a very altruistic way, understanding that they need to keep others safe. And teens are wonderful. Most teens are wonderful empaths. And even if they might have difficulty with their own impulse control at times, as many parents can probably attest to, they tend to take on the perspective of others, and that's developmentally normal. And that's a shift from early childhood into their teenage years. And that shift to understanding the perspective of others creates these heightened levels of empathy. And so I think many teens are not going to have a problem with masking, with doing frequent hand hygiene, because they know that they're keeping their classmates, their teachers, their staff safe. And I think that emphasis, not just on personal health, but health of the community and health of the school community, is a really important message to convey to them. The other important message to help them continue masking and doing all the mitigation strategies is that if they don't, they're not going to be able to go back to school. And despite all the complaining I might hear about having to go to school all the time, or parents might hear from their kids about going to school, I'm sure they get much more of teens wanting to be back in school. And that's a message I've heard from numerous teenagers who say, I can't believe I'm begging to go back to school.
Yeah, and I would say, I think that is certainly important for all families. I'm glad to hear that that's, likely to be a really important factor for teens. And I think even for younger kids and just for families in general, I think part of what makes this work is everybody really pitching in and working together to keep community rates low, to avoid gatherings outside of school that might jeopardize your ability to keep your kids in school. And so we all have a really important part to play in this, to really prioritize our kids being able to be in school and get that in-person education. To address the questions about the various mitigation strategies that can be put into place, certainly there are many options. I think that's great that we have so many different options. We don't want to just do one. We need to do as many as we can. We need to do, certainly what's feasible, and we need to be as aggressive as we can about using these strategies. There's, a saying, it's like, Swiss cheese, different layers of Swiss cheese, and any one strategy might have some holes in it. The idea, though, is that when you layer different pieces of Swiss cheese, those holes cover up each other. And so the more of these strategies that we can layer on top of one another, the more likely we are to prevent spread. And so to the question of the distancing, early on in this pandemic, the message was out there, 6 feet. 6 feet's the distance you got to keep. And that's, it's a very straightforward message. And I think that from a public health standpoint, it's important to have straightforward messaging like that. But I think we all know, and certainly understand through living through this, that science is not that straightforward. It's not that black and white. The idea of the 6 feet comes from the respiratory droplet spread. And we think that those larger respiratory droplets, which are the primary source of transmission of COVID or SARS-CoV-2, the virus, is that it's through that spread. And those tend to fall down to the ground in about the 3 to 6 foot range. And so we said, stay 6 feet apart. Most of those droplets then won't get to you. We know now that that's not completely true. There is some smaller particles that will travel longer distances. And it's also a range, it's not all droplets travel 6 feet and immediately fall to the floor. Some are going to fall sooner, some are going to fall later. And so, there's some flexibility there. So the American Academy of Pediatrics has actually come out and said that while CDC still says that 6 feet is ideal, if that's not feasible within the school setting, that alone should not be a barrier to bringing kids back to school. And, a shorter distance like 3 feet would still be a very admirable goal and is likely to have a significant impact on transmission. And so I think it's this sort of flexibility in trying to, pick and choose the mitigation strategies that are going to work the best in your environment and optimize the, stopping of transmission. That's what we're really trying to do. Wearing masks is that's a no-brainer. That's absolutely got to happen. I think that's the one thing I would say. There's just absolutely no arguments. You have to wear masks. I know there've been some questions about types of masks. I think as of right now, the CDC is still recommending that cloth masks are certainly sufficient for this kind of interaction, 2-layer cloth masks. That guidance may change over time. We'll see. But I think, that's one of the things that has to happen. But there are a lot of other things they can do. Cohorting. I think the question about, passing in the hallway, transient contact is very unlikely to spread disease. So I don't think you need to worry too much about kids walking past each other. Now, if they're congregating at lockers and talking and their faces are all close together, a mask might not be quite enough in that situation. So, schools do need to try to keep kids from congregating. They need to keep them as spaced out as possible. Eating lunches in schools is certainly a concern. Obviously, you have to take off your mask, but, keeping kids as bigger rooms as possible, increasing ventilation. So even in the winter, maybe having a window open and keeping the doors open so that the air can flow. And then limiting the amount of time that the mask is off. So, have them get their straw in their juice box before they take their mask off, that kind of a thing.
Mm-hmm. And I think this also addresses another related question that's talking about how some high schools say they can't open up because they can't keep that 6-foot distancing. So I think you've just answered that, the 6-foot distancing is a guidance, but we can go as small as 3 if that's what's possible, just because of the overwhelming benefits of getting kids back in school in person. There was another question about, we've talked so much about how important masks are, and we've been so impressed with how well kids wear masks, keep them on, and really handle it sometimes better than grown-ups. And so what if someone in the child's class has gotten a mask exemption? So I know I care for lots of kids with autism or other developmental differences where the mask is just really hard for them. We've tried different types of cloth. We've tried, different behavioral programs, and it still is a challenge. Is there another mitigation strategy that can help in a case like that? And often, hopefully with a mask exemption, it is it may be in a smaller classroom, or it may be something where there's less exposure to other children.
Yeah, that's a good question. And, I think those are tricky situations that are likely going to be best handled by discussion of all the people involved and sort of trying to find the best fit for that situation. So maybe that, maybe there's more distance between that child and others if that's possible. Certainly for staff working with those children, I think using medical grade personal protective equipment is a good idea. They should be wearing face shields and masks and things more than they would with just other students who are wearing masks. If there's, mixing of kids like that in the classroom, I think that, considering what's the risk of that child to actually contract the virus is important. Maybe that child is really, really low risk because they don't really do anything else. So I think that it's really hard to say for any given situation what the right answer is, but I think open communication between everybody involved is really important, because there may be some families that just don't want to take that risk. They can't have their kid in school if there, is increased risk of spread in the classroom. Overall, the risk of spread is low, and with lots of mitigation strategies, we keep that low. So not doing one, doesn't increase the risk dramatically, but it does increase the risk some.
I do think that it will be a common thread through a lot of our conversation of open communication with your community, with your family, about how everyone's doing, so you can adjust over time. You can look at the data from the state and your own county, but you also need to look at the data from your own family. How's everyone doing and coping and being, in terms of, are you so happy to be back at school, or, are you getting obsessed with hand washing and germophobia or other things like that? It's going to vary so much by individual child and individual family. So to talk a little bit more, go ahead.
I just want to mention the mask wearing, which again, out of all these different mitigation strategies, mask wearing remains number one for population spread. And there are a limited number of reasons for an appropriate mask exemption. And Jenny, I know you take care of a lot of kids with autistic spectrum disorder, and those are the main children I think of who just can't tolerate wearing a mask. For virtually everyone else, there really are almost no exceptions to being able to wear a mask. None of us, I don't really enjoy it, but we do what the right thing is. And again, like I said before, many of my patients will wear the mask because they want to do the right thing for their friends and for their teachers. The other thing to keep in mind when we just say wear a mask, we have to be very concrete about it in making sure that everybody's wearing the mask properly. So, and especially in kids of varying sizes, you need to make sure that you have the properly sized mask, a properly fitted mask, and it needs to go over the nose and not hang under it. I know many of our country's leaders have trouble keeping their nose in their mask, and it needs to be worn properly. And I think if people don't understand that intuitively, and kids certainly don't. So I think helping them or reminding them and helping them know how they need to wear it properly.
And I have found that even in, many of my patients who have sensory processing challenges or it just is overwhelming to them, they can, through therapy, learn how to leave it on just for certain periods of time that are most important, or we find one that has just the sensation that they can tolerate for slightly longer. So it's about, again, being flexible and being, keeping on having that mindset of trial and error and adaptation. So speaking of adaptation, there's been so many readjustments for our kids in and out of school. So I want to ask a couple questions that get more at the social and emotional and behavioral adjustments that kids are having. So let's talk about isolation from peer groups. This is one question from an audience member asking, how has this isolation from peer groups, schools, sports activities, and jobs affected everyone's mental health, especially teens? So I'm curious, how should we expect if they're going back to school? Will some of that re-entry be hard? That's my question, not the audience members. But then the audience member was asking, when do you know if you should be worried about signs of anxiety, depression, like that this isolation has reached a point that's not just like a typical adjustment to a stressor, but has reached a more concerning point?
Sure. So these are excellent questions and questions that we field on a regular basis, and it's complicated. It's complicated to figure out if the pandemic precautions that we're under have made adolescent depression and anxiety significantly worse, or if it's a continuation of a very unfortunate trend we've seen for the past 10 years. And we know that since about 2009 up until 2019, which is the last year we have data for, 2018, the last year, is that we've seen about a 50% increase in death by suicide in adolescents and young adults. And we've seen fortunately, it's still a rare occurrence, but we've seen a similar increase in rates of depressive symptoms, increasing by about a third to 40% over that time period. Girls are much more affected than boys, and about half of all girls report having a prolonged period of depression within the past year. Rates in boys are about half that. And this has been a slow, continuous worsening trend for the past decade. We have a few data points for 2020, not as robust, but it looks like those trends certainly continue and may be worsening. And in the teenagers who are the most severely affected, we're seeing a dramatic rise in referrals to mental health providers, psychiatric emergency room visits, and to our program, about a doubling of the number of patients with eating disorders referred to our program. There's a clear impact on social isolation and limiting of the normal daily activities for all of this, because it's really worthwhile to remember that one of the best treatments we have, one of the pieces of treatment for depression is getting out and doing things. So being physically active, interacting with friends, getting in there to school, and trying to live as normal a life as we can. And that has been impossible for the past year. So the most important thing is, when should parents be worried about this? And that is a really difficult question, because differentiating between being sad about, say, missing prom or missing basketball season or not seeing your friends, that's normal. We should all be sad about that. When that transitions into a more severe clinical depression can be hard to determine. Some of the guidelines we use are things like overwhelming feelings of sadness, inability to continue your activities of daily living, so difficulty with academics, increased and worsened social isolation, and certainly thoughts of death or suicide as a release from this are all concerning. And if that isolation and that difficulty with those normal activities persists for more than 2 weeks, it's really important to seek out some professional help at that point.
And it sounds like people are seeking out help, which is good. I mean, the fact that you're getting referrals, that a lot of the psychologists I know there's a lot of demand. I'm really glad that parents are reaching out. Even me, I mostly see school-aged or younger children, and I am also seeing some children who are really, showing the kind of early childhood signs of depression, which is a bit more irritability or explosiveness, or just not wanting to do the usual things that they enjoy doing. I guess a follow-up question that might be helpful for audience members is, what can we do? Let's say, teens are expected to be remote or virtual for the rest of the year. As hopefully COVID levels lighten up in our community, what are the safer things we can have kids do so that they're getting outside? For the younger kids, it's often like, okay, when is their swim lesson opening back up? Or when is the gymnastics gym that they love opening back up? Or is there a couple of buddies from the school that we can go meet at the playground with wearing masks, so that there's, you're just getting kids back into some of the social interaction and the feelings of joy or self-efficacy that can counteract some of the depression and irritability. So what would you say on the teen side of things?
Yeah, so there are a few basic things, and I'm glad you said that, Jenny. You really hit it about going outside. And as Alison had said too, more air circulation available decreases our risk of COVID, period. That's a really key. So activities outdoors are really low risk, and they're really, really good for all of us, and especially children and adolescents. And so I'll kind of jokingly tell many of my patients, you should see daylight at some point during the day. And I used to say you should see sunlight, but it's Michigan in the winter, so that's a little harder to come by. But it's really important to get outdoors every day. And if I can put in a plug for the University of Michigan Botanical Garden, if you look at their Facebook page, there's a couple programs. One is called Everyday Outdoors, and there are suggestions to go outdoors. And there's another program called Nature Play Pop-Ups, which just happened to be run by my wife, to get kids outdoors and active even during the winter, and especially during the pandemic here. The other key thing, we're probably going to get to this in a bit, it has to do with adolescent sleep. And it's really important that teens try to get up and out of bed and out of their rooms before noon. That's just like, get up in the morning at some point and get outdoors in the middle of doing your schoolwork.
Great. And let's pivot to sleep. I also just want to say we will look up some resources for teen mental health. And especially, I know there's the Trails program that works within the schools from University of Michigan. For younger families, the Zero to Thrive group has been extremely active in trying to put out supports for families whose kids are adjusting emotionally to this. So just so that there's more concrete strategies that families can look at after this.
Jenny, can I just add one thing about outdoors? Because I think that's a really excellent point, and that's not a mitigation strategy that we had talked about. But I think that's something that schools can do as well. And spending, even in the winter, I know it's hard to have class outside in the winter, but still, moving gym class outside, doing having just multiple breaks outdoors. It's good for everyone's mental health, for everyone's physical health, and it's extremely low risk. So it's really a win-win. So I know, just bundle up and get outside. So I think if your school, hasn't talked as much about doing that, it's a good question to ask, what can we do to just get kids outside more?
Yes, and I think in general, the more families who remain on virtual and remote can organize either through the school district or through your own community connections. Some of those times for kids together, that can be a helpful preventative approach. Because one of our questions was, are there certain kids that we need to be more worried about that are more prone to depression? And I think that, Dr. Bravender touched on the eating disorders or, kids with pre-existing mental health, but I think all kids could use a dose of this kind of preventative activities, outdoors, social interactions. They may be resistant to it at first, and it may be hard for kids to be re-entering the school setting as well, but kind of push through that resistance. Because, sometimes even me, when I see someone in person that I haven't seen in a year, I'm like, I forgot how to have a conversation. So we just, we're going to be rusty and expect that, and expect that your kids might have some anxiety or resistance.
I think that going outdoors and getting up out of bed is one way of trying to create a normal daily structure in the midst of an abnormal situation.
Yeah.
So it's really easy, especially if you're on asynchronous school and you're 16 years old, to just lay in your room, keep it dark, sign on to the computer sometimes, lose track of day-night cycle, and it just becomes this kind of deepening kind of spiral and closing in walls. And if you can create that time to go outside and create different parts of your day so everything doesn't seem the same, that actually can help prevent the occurrence of depression.
And that also addresses extra time on technology that families are worried about. Of course, kids are spending lots of time on virtual school or through video games or their phones because it's their form of social interaction, but it can become kind of that spirally, I have nothing else to do. There's an endless feed of stuff here for me. It's not always good media that's like, enriching your life and opening up your heart and mind. It is sometimes just bringing you down a rabbit hole. So having a change in your daily structure can also help just break kids from some of those mental tech habits that aren't really nourishing them right now. And just one last question. I know we're about halfway through the live stream. I want to touch on sleep. We have tons of questions about vaccines, about other kind of safety. So about sleep, I know one question was my teen was getting so much extra sleep during virtual school, but now they're struggling with the adjustment to regular school hours. So lots of sleep for teens is good and letting them sleep a little later, but you also just said not too much, not like past noon and taking up, the rest of the day. So can you give us a little guidance on, what's kind of some ideal sleep during this time?
Sure. So normally sleep-wake cycles for all of us, if we had no clocks, no exposure to sunlight, almost all of us would be on about a 25-hour sleep-wake cycle. So we'd have a 25-hour day. So that's why it's always easier to stay up about an hour later, but it's really hard to go to sleep an hour later. And we always have a tendency to want to stay up later and sleep later if we didn't have anything else around us. So that's one thing to keep in mind. And when you don't have a schedule, it's really easy, especially for teenagers, to completely flip their schedules around. So they might be sleeping all day and up all night. And we know that if you're sleeping during the day, you don't get as restful sleep, and up all night, it is completely disorienting. So that's why I really emphasize getting up in the morning. Now that said, teens normally have a later sleep phase than younger children do and later than adults do. So it is perfectly normal for them to feel like they need to go to sleep at 11 p.m. or midnight and sleep in until 8 or 9 a.m. That is absolutely normal. And we're a little bit behind the times here in the state of Michigan in that there are no statewide requirements regarding school start time in the morning. So one of the really tough transitions kids are going to find, they're in virtual school, able to get, the appropriate amount of sleep, not too much sleep, but the appropriate amount in a cycle that's more to their normal physiology. When they go back to school, it's going to be really hard on them. And frankly, I think it's inappropriate for schools to expect adolescents to be able to leave for school at 6 or 7 in the morning because it does not match their normal sleep-wake physiology. There are other states in the country, say Minnesota, where it's illegal for high schools to start before 8:30 in the morning. And I think if parents see this in their own teens, there's a lot of advocacy work they could do with their own schools. It's a tough balance because you have to alter the way sports practices are in the afternoon, teen jobs in the afternoon, parent work schedules, but I really think it's worth it for teen health.
Yeah, and we're certainly rethinking a lot of our schedules and the way we do things for school. So I like your message of parents observing, knowing what's good for your kid, and then being an advocate where you're engaging with your community and your school district to really try and set up the system that works best for our kids. All right, I'm going to pivot over to some questions about COVID infections in kids specifically. So this is such a tricky virus with kids. There's so many where there's no symptoms, right? So one of our audience questions, I'm going to pepper you with a bunch of different questions, Alison, so get ready. Number one, do you think the risk of spread is lower in schools because kids might get COVID but not show symptoms? So this audience member knew a family where all the kids tested positive, but only one had symptoms. So how does that asymptomatic carriage of the virus affect the fact that it's spreading or not spreading in schools? And then the second question is that you've heard about more cases of severe COVID symptoms. So do we know what the numbers are of severe COVID symptoms in kids, compared to other sort of flu types of viruses? Do we know more about the MISC, the MISC, multi-inflammatory systems associated with coronavirus? Is it more common than we initially thought? Is it actually rare? Is there data about which kids are at highest risk? Because I know as we move forward with a vaccine, we're not really close to having a vaccine for kids yet. So also, Alison, if you know anything about when those trials are starting, I bet families would love to kind of hear, when might a vaccine be available for kids? Because it just has this tricky relationship with anywhere from asymptomatic to major inflammatory disease.
Yes. All right. Well, I will do my best to answer all those, and please let me know if I missed something. But I think the first question about, is there unknown asymptomatic spread in schools is an interesting question. I don't think we have data yet where we've, systematically surveyed kids in schools to really be able to answer that question. I think what we do know from the data that we've seen is that the rate of symptomatic disease and, detected disease in kids is way lower in these school settings than it has been in other community settings. The study in Mississippi showed that, so of kids who got tested for COVID, it was much more likely for kids to have been attending social gatherings and like birthday parties and things like that, weddings, funerals, than it was for them to have been in school settings. And actually, being in a school setting for kids 2 and up with staff wearing masks was actually statistically associated with a negative test result. So, we don't exactly know why all those kids were tested, but I think, yes, I certainly think there's some unknowns. We may not know as much about what the level of asymptomatic spread is, but at the same time, we're not seeing that turn into more significant community spread. We're not seeing staff members getting infected. And we're finding that when we look at the type of risk factors that kids have who are infected, it's not the school exposure. So I think it's something we have to keep an eye on, but I am not overly concerned that there's a big, massive problem with a undetected asymptomatic spread. And I think, that's why the asymptomatic spread is why we have all these mitigation measures in place, because the kids who are symptomatic just shouldn't even be in school. So what we're trying to prevent is the spread of asymptomatic disease in schools. The symptomatic kids are just not even in the picture. Hopefully, that should be the goal. The second question about sort of severity of COVID in kids, I think, is again an interesting question. And there certainly have been, obviously severe disease of any kind in children is worrisome and makes us all very concerned and also gets a lot of media attention. And that's totally appropriate. But I think, when you look at the numbers, it's still not very concerning to me. The most recent numbers I saw, is about 1 to 1.3% of kids who get COVID are with a known case of COVID. So that doesn't even count any of the asymptomatic kids that might be out there. About 1% are hospitalized. That's still really low. Only 1 in 100 of the kids who actually get detected to have COVID get hospitalized, and only 0.01%, so about 1 in 10,000, have died. So those numbers are still very reassuring. The MISC, the multisystem inflammatory syndrome in children, this is a very interesting condition that we're still learning about. It is a reportable condition, so the CDC does keep track. So we do have a kind of steady eye on how many of those cases we're seeing. And although reporting in the most recent weeks is always a little bit delayed, we're not seeing numbers as high as we were actually even back in May. So still the highest daily case numbers occurred back in May with the rise in cases both in Detroit and in New York City. So I think it's gotten some publicity because in certain pockets of the country where they haven't had really high numbers in the past, like California, for example, they are now seeing it. And I think that's to be expected. But the likelihood of a child actually developing it is probably less than 1 in 1,000. And that's again of known COVID cases. If you look at the numbers that have been reported compared to the numbers of reported children, pediatric cases, fewer than 1 in 1,000 kids have come down with this MISC. So I think, overall, I think it's still very reassuring that the vast majority of children will not have severe disease from this infection. And I think the last question about vaccines, right?
Yeah, actually, sorry, before we go to vaccines, there's another audience question. Do you know the data for elementary age kids with asthma and whether they are having worse COVID cases or worse exacerbations the way they sometimes do with the flu?
Yeah, there's still, I don't know exact numbers. There's still pretty limited data on that because just the way the studies have been done and the way the data has been gathered. What I do know is that there's definitely not data emerging that they are more at risk for severe disease. And it seems like they may have a similar rate of disease, but we're not seeing a signal that kids with asthma specifically have a higher rate of severe disease. And one other thing I would mention along with that is just sort of locally in terms of what we see in the hospital. As this pandemic has progressed, we get daily emails with the number of patients that are hospitalized, and we've all seen that the numbers of adults that are hospitalized far surpass that of kids. And yes, there have been little times where the blip of pediatric numbers have gone up, but those have been perfectly aligned with when the adult numbers go up, and there are still just many more adults hospitalized compared to kids. So I think our experience has borne that out too, that there's still the risk of severe disease for kids is quite low.
Okay, great. And there was another question about food allergies. So I guess, kids in general who have different immune reactions or suppressed immune systems, has that, I don't know if there's anything been published about that yet, probably because the case numbers are so low, like you said, but just if there's any kind of clinical knowledge about that.
So I don't know anything, I haven't seen anything about food allergies, so I can't really speak to that. I mean, in general, I don't think we see significant differences in response to viruses among kids with food allergies. But it's in terms of immune compromise, generally speaking, patients who are mild, and this is the same for, I think, adults and children, mild to moderately immune compromised patients have really not had a substantially increased risk of severe disease. Severely immune compromised patients who've had solid organ transplants or bone marrow transplants or who are actively undergoing chemotherapy, things like that. Those patients, yes, they have increased risk of severe disease, but kids who are on maybe a mild immune modulator for some other condition, we really haven't seen those kids getting really sick.
Great. Okay. All right. We're going to shift over to vaccines. I know teens have been in some of the vaccine trials, or at least the 16-year-olds and older. Do we know about timing for vaccine rollouts for, the tween and teen category or for kids? And, we had a related question about whether teens are considered super spreaders and whether that's why we need to prioritize them. I'm going to I think it's interesting, like maybe it's not the actual people who are super spreaders, but it's the behavior that could be super spreading, just.
I think so. I don't think there's like a specific type of person that is a super spreader. At least we don't know that yet. Maybe there are certain people who have some genetic predisposition to have more virus in their nose and therefore they're, we don't know that yet, but it's not been identified. I agree. It's more the setting. There are these super spreading events. I think that young adults, teens could easily be the index case in those super spreading events if put into the right scenario. But I don't think they're more likely to be super spreaders than adults. I think it's just a matter of, it's more the situation that they're in. That's what really has to be controlled. So I'm happy to talk about vaccines. So as I'm sure everybody knows, the Pfizer and Moderna vaccines have been FDA approved. Pfizer's been approved down to 16, so they included 16 and up in those trials. Moderna's down to 18. Both companies have active trials ongoing to look at the vaccine down to age 12. So Pfizer has actually completed enrollment for kids ages 12 to 15, and Moderna is still enrolling kids ages 12 to 18. I actually looked recently and I didn't see that there are any sites in Michigan that were enrolling, in case that question comes up. So certainly nothing really locally if you're interested, but it's actually, if you're an internet person who likes to look around, clinicaltrials.gov is the website where all this information is available, and you can pretty easily search and find these trials. So I think I think for the 12 and up group, I'm hopeful that we'll have some data fairly soon in the next several months. I don't know that there's been a specific timeline given, but my hope is that maybe by the end of the summer. I think also keeping in mind that most 12 to 16-year-olds are generally healthy. They're probably going to fall into the bucket of the last sort of tier of vaccinations. So I know the state of Michigan actually just released kind of a nice infographic about when they expect 16 and up, otherwise healthy people to be vaccinated. And they're saying like August, September. And I would, just say if the vaccine is approved down to 12 by then, I would expect that those kids would also fall into that bucket. And remains to be seen exactly how it plays out. But my hope is that maybe by late summer, that we could start getting our 12 and up kids vaccinated. The kids less than 12, those trials haven't started yet. So I think it's going to be a while longer before we have that data. And especially for younger kids, it gets more complicated because they don't always get a full dose of the vaccine. So it is a little bit trickier. There's just more that goes into researching the vaccine for that age group, although they don't necessarily have to go through the entire rigorous trials that have been done before. So I've seen some estimates of maybe late 2021 being like the earliest that we would expect to see the vaccine available for kids under 12. So I think that's probably, I would be surprised if it was much before late 2021.
Yeah, and I'm getting questions about like, what are we going to expect for next fall when schools are reopening in the fall? Are we going to expect that kids are vaccinated? And I've been telling families, no, I wouldn't expect that young kids are being vaccinated, but I am expecting, at least the way the models show, is that the community rates are going to be much, much lower. And that's going to reduce the chances that you have a child infected or even asymptomatically infected with COVID. And that's what's, again, it's like all those layers of things, the lower community levels, all the mitigation strategies, the vaccination of teachers and other first-line workers. So that's hopefully what'll be more reassuring.
Yeah, absolutely.
So, Terry, what do you think? What are you hearing from teens about their interest in vaccination?
Not much at all. I think they don't view themselves at risk, and I think they're well aware that they're on the low priority list of people to get the vaccine. I think the best advocacy we can do for schools is to make sure that all the teachers get vaccinated. And there've been a number of school districts, at least one in I think down in Georgia, that had to close because they didn't have enough teachers available. The kids were probably asymptomatic carriers or not infected at all. And the teachers, there were so many sick that the school had to shut down for that. So I'm glad to see teachers on the high priority list along with for other frontline workers. I think, again, I think most teens are just, when they're told they need a shot, they're like, fine, I'll get a shot, and aren't considering whether it's coronavirus or not. And I think the perception that most of them have is true, that they're at, even though they have to pay attention to it, personally, most of them are at very low risk of complications.
About the subset of us who've now been vaccinated, I got my dose 2 yesterday, and teachers are now starting to get vaccinations and other, first line essential workers. So there was a question about should vaccinated teachers or any of us who are fortunate to be vaccinated early, but when we have family members that are non-vaccinated, how do we worry and think about the risk of exposure? So we are vaccinated because we're going into clinics or we're going into schools or grocery stores or other things where we're seeing more people. And so could we get it and spread it to non-vaccinated members? A related question was the reverse. If your grandparents have been vaccinated and no one else in the family has been vaccinated, how do we navigate those interactions now? Do we and I would just say, like, from my experience talking with lots of medical providers, no one's like, yeah, I'm going on vacation, I'm like going out to bars now. It's like everyone's still using all the different layers of mitigation strategies just to protect our community. But what else, should we be thinking about in terms of these new, non-vaccinated folks in our circle?
Yeah, I think, so I think you're absolutely right. There's, these vaccines the Moderna and Pfizer vaccines are, remarkably effective, which is amazing and a very welcome development in this pandemic. But they're not 100% effective. They're also very effective against severe disease, but again, not 100% effective. So I think that's important to keep in mind. And one piece of information that we don't have yet that's very important is that we don't know if people who are vaccinated can still be infected and asymptomatically transmit the virus. So the trials really looked at symptomatic disease. So there's still a lot of uncertainty about how that could play out. And I think that's absolutely, important to understand. And that's why the CDC is still saying you should still be wearing a mask. You should still be doing all those things. I think, when it comes to sort of personal decisions within your own family, I mean, obviously a vaccinated person is at lower risk of getting sick than an unvaccinated person. So, I mean, I think that you can use some reason there, but I think you have to just remember that it's not perfect. And so I think a lot of it's going to depend on, do you let your kids see their grandparents? Well, once the grandparents are vaccinated, well, what are you doing? Are you going outside to a park? Great. Are you, still wearing masks? I mean, so you maybe can have some other safety measures in place to sort of work on that small risk that still exists, or maybe you just really can't still take that risk yet. I mean, I think that's another decision you could make. And I think, again, it's talking with everybody involved and really just being upfront about what the risks are and how we're going to manage them. I think as community numbers get lower, then that level of imperfect perfection is less important. But because community levels are still pretty high, there's still a reasonable opportunity that you're going to get exposed. And so that small 5%, imperfection of the vaccine is still relevant at this point in time. And I think, as the question of like teachers being vaccinated in schools, I think absolutely we need to be prioritizing getting teachers vaccinated. But, we've already shown that schools are safe for teachers even when they're not vaccinated. So that by itself does not need to be a goalpost for opening schools, but of course we should be doing everything we can to protect those teachers once they're in schools. And I think for the fall, I agree, like that's going to be the big thing, is that by the fall, the teachers should all be well protected, and I think the rates will be lower. And the kids, as much as I'd love my children to get vaccinated, they are at the lowest risk, so they probably should get it last.
Thanks for bringing that up, Alison, for that clarification, because the study I cited, the teachers who contracted coronavirus probably got it from community spread and not directly from being in the school. And so I guess if we want to keep our schools open, it's more important that the teachers take all of their precautions, including vaccination, so that they can continue teaching.
Yeah, I'm actually glad you mentioned that again, because I wanted to circle back to that, because I think there's understandably concern about teachers getting sick in schools, but I think the bigger risk to teachers is other adults, and whether that's adults in the community, because you're still going to birthday parties or baby showers or whatever it be in the community, or other adults in your school. It's very important that staff maintain these precautions around each other. I think that's a bigger risk to the teachers than the kids themselves. And we've seen that in the hospital, that where staff are getting infected in the hospital is when they are taking their masks off and eating together in break rooms for prolonged periods of time. That's the major risk. And so it's these activities that are outside of school, that are in the community, that are outside of the classroom, that I think we have to still pay really close attention to. Absolutely, the classroom's important and we need to reduce risk there as well, but we can't forget all of the other places where you're likely to get coronavirus.
Yep. Now, in the last cluster of questions, I'm mostly going to be asking about, kind of moving forward as we move into this like later winter and spring. How do we help families make decisions about sports, about participation in summer camp, about feeling like they need to catch up? If they have special needs, they haven't had the supports they need. How do you try to help them catch up without overwhelming them? How do you peel back their media use? I think there's lots of different changes that we don't want to overwhelm kids with all at once. But there's a great audience question about what should families be considering as they think ahead to summer camps. But let's also add other sports, other activities that are going to involve more contact with other kids. There was a question about a study on student athletes showing heart damage after COVID. So is there a medical reason that we should be more cautious about letting kids return to play if they've had COVID? If we have time, I'm happy to answer some questions about those of our kids who are going to continue in remote learning. How do you keep them engaged? How do you keep them motivated and interested and not distracted? So let's start with summer camps and sports, and then we'll see what we have time for.
So I think sports are incredibly important for engaging kids with their school, and the key theme to sports always is sports should be fun. That's why kids participate in sports. And I am not interested in people trying to create the next Wayne Gretzky or the next superstar professional player. The real value in sports is enjoyment of movement, physical activity, having fun with your friends, and certainly in high school, creating a feeling of connection with your school, which we know helps with academic achievement. So when kids are pulled out of sports because of coronavirus, all of those things suffer. So I think when they return, we need to balance the risk of contracting coronavirus, what's the risk to them, with all of those positive benefits. And I think that if, from my perspective, if it's safe enough to be in school, it's probably safe enough for them to be participating in the sports they want to participate in. I think that the schools that have pushed forward some sports without having in-person classes, I'm not really sure the value in that. And those two things don't make a lot of sense in my mind. So for parents making these decisions, remember that those two risk analyses should be linked. I know there was a study out of Northwestern that looked at myocarditis in college athletes post-coronavirus, and Alison may know more information about that. I think there are markers of heart inflammation without necessarily clinical correlations with that. So I think the jury is still out on those risks. I think it's important to continue to monitor, but I don't think at this point that should restrict certainly the amateur athletes and middle school and high school athletes from participating in things that they love.
Yeah, I agree. And I think if your child had a severe episode of COVID or MIS-C, and there's a good chance they're already going to be seeing a cardiologist anyway that you can speak to about that risk. But for the average kid who has just a mild case, there's nothing at this point that's telling us that they shouldn't go back to sports when they feel better.
I think that, remember, the decision matrix for this is going to be a little bit different too, depending on the sport. So I think some sports are extraordinarily low risk. So if your child is a track athlete, running outdoors is going to be low risk at any point in the past year.
Yeah.
Other things, indoor sports, basketball or volleyball, there may be more precautions that need to be taken place, but as we move into spring, I think outdoor sports are a really great opportunity to help kids get back some normalcy in their lives.
We did have an audience question about not just sports or camps, but what about theater, robotics, other clubs that usually occur indoors? And I guess some of those can be adapted to outdoor settings if weather permits, but I assume that if kids are able to go to socially distanced school with, ways to reduce viral spread, that, similar modifications could be made for those sorts of activities. It's harder to sing with a mask on or play an instrument or things like that, but the same sorts of procedures to reduce infection risk should all apply to those.
Yeah, I mean, I think those things can be gradually rolled out. I think, first and foremost, I think we have to focus on getting in-person school going and everybody getting comfortable with that and getting our mitigation strategies in place. And then I think once we're in that setting, we'll be more comfortable and understand what works. And then, can gradually add back these activities. And hopefully that will also happen as rates go down and more people are vaccinated. I think it'll gradually build. And I agree with the sports comment. There was actually just a study that came out about a wrestling match where there was a high tournament, actually, where there was a high rate of spread of COVID. And I think that, certainly wrestling is not a sport that is socially distanced. So it's going to be, there's going to have to be some individual considerations for each sport. And also surrounding those sports, there's a lot of gathering and time in locker rooms and, maybe there's, meals or things that happen around those. So those are also important things to consider, really focusing on the important, like if you want to play the sport, playing the sport is the most important thing. Drop the other stuff, and I think that's another thing to think about too, is not just the sport, but what are the activities happening around it and how can we lower risk really any way we can.
Great. All right. We have just reached 1 o'clock. Thank you for getting to all of my questions that I've packed together. I really want to thank Drs. Tribble and Bravender for joining me today and for getting to so many audience questions. And thanks to our audience for spending this part of your day with us. So stay up to date on the latest COVID-19 information. So we have a resource page, the mottchildren.org/COVID update. And we hope that this chat today has been helpful. So have a wonderful afternoon. And like I said, we'll post some of the resources we talked about to help kids adjust as the spring goes on.